one can join.
Okay. We'll be joining at 8:05, I think so. So shall we start?
Yeah, I think we can start.
Yeah, it's
She's
8.
there. She's also from same institute.
Yeah.
So we can, yeah.
Good evening, one and all. As we have a curtain for 2024, it's our 42nd meeting, monthly meeting of peculiar case studies and renal transplant. And this 1 year has seen a very good number of cases, peculiar cases and tricky situations. And we had a lot of discussions over the transplant scenarios. And people are very much, they are contributing to this transplant. And nice to see this forum is developing and this group is becoming big and bigger. And as we come to this, this is our 42nd meeting, monthly meeting, and by God's grace is going uninterrupted. And luckily, this scenario, this is the last meeting of 2024. And this scenarios luckily happen to be both of the peculiar cases, mostly from transplant infections. And joining this, it's one of the panelists. We are lucky and to have Dr. Shyam Bansal, and he's a director and HOD of nephrology at Danta, Gurgaon. And this forum doesn't need much introduction about him because he's a secretary of ISN. He's doing a tremendous work as a secretary ISN, and he's fortunate. And we are fortunate to have a WCN 2025 in India, and he's one of the chair organizing committee of WCN 2025. And we wish you a great success for the event. And his academic accolades are many, and he's one of the first to report 100 ABO coming to transplant, HLA sensitized to transplant. And he's particularly very much interested in transplant infectious disease. And this forum is an ideal him to give his inputs, and we can learn much from him, I hope. And the case will be presented by his resident. First case will be presented by his resident. And when we asked about the gist of the cases, and he's told that that's very interesting and that will spoil whole discussion. So we will be waiting to unfold the case, and we'll have a good discussion. Hope we'll have a good discussion over there. And second panelist is Dr. Saurabh Sharma. He's from Bardhaman Medical College and Safdarjung Hospital. He's an assistant professor over there. And I met him at ISOT, and he's been delivering a talk and all. He's astute nephrologist, and he's one of the member strengthening committee National NOTA and the technical expert group CKD, and he's deputy chair dialysis working group International Society of Nephrology, and he's member South Asian Regional Board International Society of Nephrology, and he's one of the mentor of ISN mentorship program, and he's a social media editor of NDT. And hope. And the second case will be delivered by his resident, Dr. Shukriti Arora. And this is also a immediate post-transplant duty post. So we have a post-transplant infection scenarios. And both presenters will be first will be Vaishali, Dr. Vaishali from DNB resident from Medanta, and she'll be guided by Dr. Shyam, and she'll be presenting her first case, and followed by Dr. Shukriti, who is she's a resident from Bardhaman Mahavir Medical College in Safdarjung Hospital, and she'll be presenting a second case. Without wasting much of the time, I invite Dr. Vaishali to start her presentation.
Yeah. Good evening, sir. Thank you. I'll share my slides.
Yeah. Make it a full screen. Yeah.
So is it visible, sir?
Yeah. Go ahead, please.
So good evening, everyone. I shall be presenting the case of an intriguing diagnosis in a post-kidney transplant patient under the guidance of Dr. Shyam Bihari Bansal, sir, Senior Director and Head at Nephrology, Medanta. My case is a 59 years old male resident of Bihar, employed in coal mining industry in Chhattisgarh. He's a known case of type 2 diabetes mellitus and hypertension since 2007, and known case of chronic kidney disease since 2016 on maintenance hemodialysis thrice weekly since 2021, with access being left radiocephalic AV fistula. There is no history of catheter-related bloodstream infections or other infections during his dialysis vintage. He subsequently underwent kidney transplant with unrelated donor at an outside hospital on 16th January 2024 with thymoglobulin induction at 3 milligram per kg. He was started on triple immunosuppression, that is tacrolimus, mycophenolate, and steroids, and he was switched to azathioprine in June 2024 in view of persistent loose stools. He received cotrimoxazole and valganciclovir for prophylaxis for 6 months till July 2024. His post-transplant period subsequently remained uneventful and his creatinine remained stable around 1 to 1.2. He was in regular follow-up with his nephrologist with optimization of drug doses of tacrolimus according to the drug levels. Blood sugar levels were in range with insulin therapy. In September 2024, he started to notice a few palpable red-colored lesions over both upper and lower limbs. Just a second, sir, I'll use a pointer. It was associated with mild tenderness and not associated with fever or itching. He did not take any treatment for same. He was advised CRP levels by his consulting nephrologist, which came out to be 270. So he was advised admission in view of same according to the patient himself and his history at an outside hospital in end of September. He developed cough and expectoration during the course of hospital stay, and his sputum culture showed growth of Pseudomonas, which was managed with IV meropenem and levofloxacin. Other detailed records of the admission, including his HRCT chest, were not available, and he was subsequently discharged in mid of October on valganciclovir 450 milligram twice daily and oral antibiotics. Plasma CMV record of that time is not available. On follow-up after the discharge on 26th October, in view of leukopenia, that is TLC of around 1,000, his valganciclovir and azathioprine were withheld, and he was managed with 2 doses of granulocyte colony stimulating factor stimulators they were given. On 2nd November, subsequently, as part of follow-up, we could see his plasma CMV copies report, which was 95,000 copies per ml. And he was restarted on valganciclovir 450 milligram twice daily at this time, as azathioprine was kept on hold. So now he had presented to us at Medanta on 10th November 2024 with complaint of multiple nodular red-colored painful skin lesions, which are now increased in size and number over the last 1 to 2 months, and it was not associated with itching. There was complaint of generalized body ache and pain in multiple joints of wrists, bilateral wrist, ankle, and knees since 1 month, and fever low grade for last 10 days. There is also history of paresthesias in both soles for last 10 to 15 days, which was associated with difficulty in walking. On examination, his general condition was fair. Patient was conscious, oriented to time, place, and person. His pulse rate was 80 per minute, regular, good volume, no radial or radiofemoral delay. His blood pressure was 130 by 70 in right brachial artery in sitting position, and respiratory rate was 12 per minute. He was afebrile at the time of admission. So on local examination, as we see in these pictures, this is the extensor aspect of his leg, extensor aspect of his arm, and this is the hand of the patient. We see here nodular erythematous lesions, which were tendered to touch, and they were present on the extensor surface. Some of the lesions had shown few ulcerations also of the overlying
Actually,
skin.
yeah, can you stop here? So
Yes.
any guesses by anyone at this time what it could be? It's open, I think everybody is there. So if anybody wants to make any comments about these lesions, Pheo, LIFO, Pallavi Astral,
Nocardia.
Nocardia. Okay. Any other? Nothing. So Vaishali, then go ahead.
Yes, sir. So systemic examination, we did sensory system examination in the CNS. It was normal. Power was decreased in dorsiflexion at bilateral ankle joints, and it was fiber 5 in rest of all muscle groups. Rest of the CNS and systemic examination was within normal limit. So after all this systemic examination and local examination, we came to possible differentials of query drug reactions since patient had taken recently antibiotics he had taken. And second differential was it could be some infective etiology in the form of any bacterial, fungal, or maybe some skin manifestation of CMV itself, or
Yeah.
maybe any other infective cause. And last of all, down the line, we kept
Any more guesses by anyone? So this, I think we can wait here for 30 seconds. and then what any guess, any wild guesses are welcome. Well, so examination is complete, the picture is there. What can we think? So, okay, Roshali, I
Okay,
think if
there is
there are
no
no more comments, we can continue.
continue.
Yes, sir. So we went ahead with the investigations of the patient on blood investigations during the course of hospital stay. His CBC blood count, hemoglobin, TLC, platelet were all within normal limits. His serum creatinine continued to be in normal range, and serum electrolytes were normal. LFTs were also normal. On further workup, his B12 levels we did in view of paresthesias, it was normal. CPK in view of myalgias, it was also normal, 28. His tacrolimus levels were 7.8, same dose was continued. His viral markers were non-reactive. Plasma CMV, we repeated in our setting, it was 5020 copies per ml. We also did some autoimmune workup for the patient, ANA, anti-dsDNA, ENA profile, all of them, they were negative. Chest X-ray, knee, wrist, which were done in view of joint pains and arthralgias, which they were also within normal limits. So we subsequently went ahead with the skin biopsy. That was only thing option left with us to come to a conclusive diagnosis. As we can see in this picture, there was lobular paniculitis according on 40X. That is, there was inflammation of and inflammatory infiltrates were present in subcutaneous fat. In 40X, the picture is not very clear, but we can see largely majorly inflammatory infiltrates. So this is the 100X image. Here we see periadnexal and perifollicular and perivascular inflammatory infiltrate. So these gap areas that we see, these are hair follicles, and near to them, these are the adnexa, sebaceous glands. So along the adnexal area, that is around the hair follicle, and in the around the sebaceous gland, there is a lot of inflammatory infiltrates present. Also along the vessels, as we see here, also one vessel is here. Around the vessel, also we see a lot of infiltrates. So periadnexal and perivascular inflammatory infiltrate at 100X. It was subsequently zoomed to 400X, and we could see mixed inflammatory infiltrate. So this is the hair follicle here, and we can see mixed inflammatory infiltrate in the form of neutrophils around the hair follicles, multiloculated nucleus we can see here, multiple neutrophils, and in the background there are multiple lymphocytes also indicative of some form of chronic inflammation going on in the background. Very little cytoplasm and large nucleolus, so a mixed inflammatory infiltrate in the form of neutrophils and lymphocytes were present in periadnexal and perivascular area. So
It seems to be more interesting. And any other differential diagnosis from the audiences? Actually, skin lesions, tender skin lesions, or the extensor aspects, as well as paresthesia. With there is no granuloma in the
no, sir,
HP.
There was no granuloma on the slides.
In a chat box, I could see another one, actually Hansen's and atypical mycobacteria.
Yeah. Specially show the picture.
So in view of high suspicion by the pathologist, they run a specific stain weight fight stain on 400X. We could see pink bacilli here in the periadnexal area. So it is specific for Mycobacterium leprae, weight fight stain. So we could stain the bacteria on the same stain, and the diagnosis that was made on the biopsy, it was erythema nodosum leprosum. So it is an immunological reaction caused by Mycobacterium leprae. Sorry. Yeah.
Yeah, so it is leprosy.
Super.
Yeah.
So we also did his NCV studies, and we noticed bilateral peroneal axonal neuropathy. Peroneal nerve is one of the major nerves involved in leprosy. And on asking retrospectively about his history of any contact or family history or past history of such lesions, he denied for the same. So we came to the final diagnosis of in a post-kidney transplant patient with history of type 2 long-standing type 2 diabetes mellitus and presenting with nodular ulcerative lesions along with systemic features and nerve involvement, and biopsy showing mixed inflammatory infiltrate with lepra stain positive. So we came to the diagnosis of erythema nodosum leprosum, that is type 2 lepra reaction in the setting of CMV infection. He was started on multi-drug therapy with rifampicin 600 milligram once a month and clofazimine on day 1 of each month 300 milligram, followed by 50 milligram once daily from day 2 to day 30. He was also started on Dapsone 100 milligram once daily. His steroids dose were increased to 0.5 milligram per kg per day, and valganciclovir 450 milligram twice daily was continued. So after 3 to 4 days of starting treatment, there was significant improvement in at least his systemic features in the form of myalgias and arthralgias, which were much better. Also, the skin lesions, they had become less painful and scabbing had started, and there was nodularity was subsiding. This is week 3 follow-up of the patient after starting MDT. We can see brawny induration, which is classical of resolving ENL on multi-drug therapy. The nodularity is subsiding, the pain is much better as per the patient. So coming to the discussion, leprosy is probably the oldest disease known to mankind. According to WHO 2022 report, prevalence of leprosy is 21.1 cases per 10,000 population in 1985, and now it has decreased to 0.21 in 2022. Males are slightly more susceptible to the disease, and 4 major endemic regions are India, Brazil, Indonesia, and Bangladesh. Elimination as per WHO, it is defined as less than 1 case per 10,000 population in endemic countries. Indian data says, according to National Leprosy Elimination Program of 2023, prevalence rate has come down from 0.69 cases per 10,000 population in 2014 to 0.45 cases in 2022. Chhattisgarh is the most endemic area for the same, with prevalence as high as 2.3 cases per 10,000 population. Other more common areas of endemicity of leprosy are Madhya Pradesh, Orissa, Jharkhand, and Bihar in India, of which our patient was the resident. Bihar, he initially was born there, and later on he worked whole his life in Jharkhand and Chhattisgarh. So clinical presentation is defined by Ridley-Joplin classification, according to which there are 5 major classes of leprosy and its presentation. On the tuberculoid spectrum, we see majorly macular erythematous lesions, and moving towards the lepromatous spectrum, the lesions are more commonly plaque and nodular-like, and typical leonine faces in the form of madirosis, that is loss of eyebrows, infiltrated earlobes, and rodent nasal bridge are seen. The lesions are asymmetric and have an associated anesthetic skin patch on the tuberculate side, and become more symmetric with no associated anesthesia of the skin lesions on the lepromatous side. Type 1 reaction, that is immunological reaction, type 1, type 2, type 1 is more common in borderline group, and type 2 is more commonly seen in lepromatous groups. On histopathology, classically granulomas are seen, and with few bacilli being detected on the tuberculoid spectrum. However, on the lepromatous side, we see more of fomium macrophages and acid fast bacilli in large number. Treatment, as we started in our patient, that is the same with Dapsone, rifampicin, and clofazimine. We go for 6 months therapy in tuberculoid cases, and in lepromatous cases, we go for 12 months as per WHO recommendation. So immunological reaction that we saw in our patient, basically the immunological reactions, they are of 2 types in leprosy, that is type 1 and type 2. Type 1 is majorly reversal reaction, which is seen majorly in borderline group, and herein we see that there is increasing redness and swelling of the already present lesions, which may also ulcerate, and there is marked edema along with. There is new onset neuritis and associated pain and paresthesias or numbness related to same. However, in type 2 reaction, we see, which is there in lepromatous group, there is new onset painful and tender nodular lesions, which we saw in our patient on extensor aspect, along with ulceration of some. And new onset neuritis can be seen here also. However, systemic features in the form of fever, malaise, lymphadenitis, uveitis, they are more common in ENL group rather than type 1 reaction. Diagnosis is largely clinical for both. However, for type 2, classical histopathological findings are there that we saw in our patient. Mixed inflammatory infiltrate in the form of neutrophils on the background of chronic inflammation characterized by a lot of lymphocytes in the background, which are largely periadnexal and perivascular, along with huge bacilli load of M. leprae. So type 1 reaction usually occurs because of delayed type hypersensitivity, and type 2 largely because of type 3 hypersensitivity reaction and altering ratio of CD4 to CD8 cells, and majorly precipitated by some form of stress, concurrent illness, or some drugs. Treatment of the reactions, they involve, we have to go forward with multi-drug therapy that has to be continued and that has to be started if it is a new onset reaction. And mild reaction, we go with rest, supportive measures, and NSAIDs only. For moderate to severe reactions, we start steroids from 0.5 to 1 milligram per kg per day for at least 12 weeks. This is for normal patients recommended by WHO guidelines 2018. And thalidomide can also be tried in type 2 reaction. It is FDA approved also for the same. Status of leprosy in setting of immunosuppression, it is rarely associated with immunosuppression according to the case reports. There are only fewer cases published in leprosy in setting of solid organ transplantation, chemotherapy, and HIV infection. As far as we could review the literature, we could only find around 15 such case reports in renal transplant patients since 1989. And usually all the cases, they have been occurring 2 years post-transplant, more than 2 years post-transplant. The reasons that have been proposed in the literature could be due to tapering of immunosuppressants and increasing immunity and increasing immune reaction by the patient in setting of same. So peculiarities in our case that patient presented in first year post-transplant itself, and erythema nodosum leprosum was itself the initial presentation of leprosy rather than being on tuberculoid or lepromatous spectrum, an immunological reaction presenting as leprosy for the first time. And any relation with CMV infection that we do not know could be there in our case. Challenges in a post-transplant patient that we can face is the masquerading diagnosis that we could have a lot of differential for such skin diseases which can have a rare cause. And there are no available guidelines for leprosy management in immunocompromised patient. Duration and dose of steroids in the setting of CMV infection, that was another challenge we are facing. Drug-drug interaction in the form of rifampicin with tacrolimus is another challenge. Questions that are unanswered and are open in after this case are whether secondary prophylaxis should be required in patients undergoing transplant with his past history of leprosy, and another being how long, if the patient has developed leprosy after post-transplant, how long should be the duration of multi-drug therapy.
Yeah, thank you, Vaishali. You presented very well. So any questions or comments are most welcome. So this is one of the, I think, rare cases. So we did not disclose the diagnosis initially.
Vaishal, it's a wonderful presentation. You presented neatly and clearly. And congratulations for making the diagnosis and getting away with the diagnosis and being the patient. My question is, this is erythematous lesions. It's a paniculitis along with paresthesia. So any other differential diagnosis, had there not been any acid phosphatase detected, would there be any other differentials you could think of?
Vaishali?
Yes, so paresthesia, the setting of paresthesias,
Yeah.
largely only Hansen's that we could think, but
Yeah.
But that also it came up late in the mind after we could do
Yeah.
the CMV was one thing which we were thinking, and autoimmune causes as well, because patient had some form of malar rash along with. So
Right.
that was one differential from our side. And CMV also presenting in the form of nodular disease, nodular lesions was one differential, but that is again a very rare presentation.
Another important thing, herpes simplex can present in such a way with the paniculitis and paresthesias. We have seen 1 or 2 patients of that. And that also one of the differentials. If you have, if you don't pick up any acid phosphatase here, and you have a panicleitis, only panicleitis with this. A very common association. Herpes simplex is commonly associated with this. HIV can present like this. Retroviral HIV can present like, and of course, you have told about leprosy. ENL is one of the important differentials. Dr. Shyam, your comments?
No, I think ultimately because see in transplant it is always the histopathology or the microbiology which is most important. That's how you make the diagnosis. Ultimately, the one that you should get a tissue diagnosis as soon as possible, and then only you can treat the because when then anything can occur, and sometimes the presentation is not classical in cases patients who are immunocompromised. So.
Definitely.
So that is the one thing we should do, tissue diagnosis as soon as possible and get the patient on right treatment.
And Dr. Sham, actually, regarding this, she has raised one question: how long the therapy for this kind of post-transplant leprosy is that? Have you come across any literature and any your experience of how much duration has to be given? Either it's
Literature,
a standard.
there are very few case reports only. So
Okay.
there's no literature. But what if I take from the like treatment of tuberculosis, so like in tuberculosis, also we usually increase the duration to the double. Normally, if you go 6 months in transplant recipient, you would like to give at least a year. So in this case, we will plan for 18 to 24 months, at least for 1.5 years. That's what our plan is because immunosuppression is there. So let's see. At least 1 year is recommended for the normal general population. For this patient, I think 18 to 24 months. That because this is something new and there is no
Yeah.
available guidelines or literature.
I think we can publish. Okay, sir.
Yeah, that's planned. Yeah, definitely.
Okay. Dr. Saurabh, I think has joined. Dr. Saurabh?
Any other questions or any comment from anybody?
Comments there actually. Lyme's disease, one of the important, they have given us. Yes, of course, it's peripheral neuropathy with nodular lesions, Lyme's disease, but not common in our area of concern. Syphilis is one of the important differentials, syphilis, but also that's not much common. These are all the differentials of panicleitis, like lesions with paresthesia. And histiocytosis, somebody raised the question of histiocytosis because you see a lot of histiocytes. Could it present like this, like any clues and any answers?
So,
Dr. Pallavi actually has typed histiocytosis.
Actually, sir, histiocytosis and pheohyphomycosis, these two, surprisingly, I've seen some very rare cases. Obviously, we shouldn't take a rare diagnosis everywhere, but they look very similar to the current lesion, which is why that was the first thing which occurred to me. We even published a case series in Indian Journal of Transplant. That was when I was working in SRMC. So I think most of the cases of pheohyphomycosis have been reported from Chennai and Pondicherry, that areas somehow. The other thing, like actually the look of the lesion, it definitely looks like an erythema nodosum. But the first thing which comes to mind with erythema nodosum is TB. Like that's what all of us have always thought about. So even despite the history of like the neurological thing which you had mentioned, Hansen's definitely didn't come to mind.
Okay. Dr. Saurabh, I think.
Yeah, good
I
evening.
think
Good evening.
yeah. Good evening, Saurabh. Your comments, I think you have joined, you have seen the presentation, no? Your comments, please.
Actually, the first presentation I didn't go through. I'm sorry for that.
Okay.
okay, so I think Sally did a wonderful job, and Rajana
Yeah.
can now start second case. Thank you very much.
Okay. Thank you very much. Thank you, Dr. Vaishali, for your wonderful presentation. And I invite Dr. Shukriti to start her new second presentation.
Good evening, everyone. I'm Dr. Sukriti Arora, senior resident working at Safdarjung Hospital. I'll be presenting a case to you, which is urinary tract infection immediately occurring in post-transplant patients. Mrs. H, 53-year-old female, known case of chronic kidney disease, stage 5, who was on maintenance hemodialysis. She presented to us with the history of CKD and had undergone 240 dialysis. On examination, the viral markers were negative and the native kidney urine output was 800 ml. On 17th of October 2024, she underwent live-related renal transplantation where the mother was the donor and she was 3/6 haplo match and CDC and flow cross match was negative. We induced the patient with basiliximab and maintenance was given using tacrolimus, MMF and prednisolone. Post-transplant, the baseline serum creatinine was 1.5 milligrams per deciliter. Intraoperative following the live-related robotic renal transplantation, the intraoperative details in that the patient underwent transplantation and single renal artery was anastomosed with the left external iliac artery and single renal vein was anastomosed with the left external iliac vein. The warm ischemia time was slightly prolonged because initially the surgery was performed on the right side. However, the surgeons found that there was a thrombosis there and therefore had to undergo another surgery on the other side, and therefore the anastomosis was done the opposite side, that is the left side. The estimated blood loss during the surgery was 450 ml and the total duration of the surgery was 7 hours 30 minutes. The Foley's catheter was removed on day 6 and on discharge, that is day 8, the stent was in situ at the time of discharge. The patient presented to us again on day 21 post-surgery, that is 7th of November 2024, with the complaints of fever with chills since 3 days, left lower abdominal pain since 3 days, dyspepsia, nausea, vomiting and decreased intake, with the history of rise in serum creatinine, and left hip joint pain since 3 days. On examination, the vitals were stable, but the systemic examination was within normal limits, but on per abdomen, the patient was found to have left-sided graft bitterness. The provisional diagnosis following the examination was made of graft dysfunction, query secondary to graft pyelonephritis. Therefore, an initial workup was done on day 0 of admission, and hemoglobin was found to be 7.3. The total counts were 14.7, and serum creatinine baseline following after the readmission was 2.58. That is, it was an increasing trend, and the peripheral smear showed no signs of hemolysis. The urine routine microscopy showed 60 to 70 pus cells, 20 to 25 RBCs, and 4 to 6 epithelial cells with leukocyte esterase positive. On 7th of November, we also sent the regular routine fever workup, which was negative, including the serum procal levels. The blood culture sensitivity and the urine report was awaited. Chest X-ray was within normal limits. An ultrasound was performed for the graft kidney, where the transplanted kidney showed mild dilated pelvic calcium system. However, the rest of the ultrasound was normal. A revised diagnosis was made where the patient was considered to have urosepsis secondary to graft pyelonephritis with graft dysfunction and anemia. Therefore, a treatment was initiated on day 1 of admission, which included piperacillin, tazobactam, and levofloxacin IV antibiotics, and MMF, prednisolone, and tacrolimus were continued with renal modified doses of Valgan, cyclovir, and Septran. After that, we followed up with the blood culture and the urine culture reports, and both of them showed the growth of E. coli sensitive to amikacin, colistin, and gentamicin. Therefore, a revised diagnosis was made where the patient was found to have MDR E. coli, resulting in graft pyelonephritis. Therefore, the treatment was revised, and this time we escalated the antibiotics to ceftazidime, avibactam, and injection meropenem. The rest of the treatment was continued.
But the patient was sensitive to any of these medicine?
Sir, initially we had started Piptaz and levofloxacin because they were sensitive to aminoglycosides. However, keeping in consideration that the patient was post-transplant and there were renal parameters to be kept in mind, we had started on those. And these were not sensitive, but because of the renal parameters keeping in mind, we started them this. Because since the patient was E. coli MDRO, this was found to be one of the antibiotics which the patient could have responded to.
No, but did they do the sensitivity with meropenem
No,
and
sir,
sofosbuvir?
we had not checked for this one. The report did not mention anything regarding these antibiotics, but the others were
meropenem का तो
aminoglycosides.
हुआ होगा ना sensitivity?
सर इनका नहीं हुआ था.
Sir, I think it was sensitive. It was resistant to meropenem, but it was ceftazidime avibactam had not been done. So we
Okay.
asked them to put additional sensitivities for the same, and started ceftazidime avibactam like simultaneously. But they took some time to get back to us eventually to tell that it was resistant to that.
Okay, but because usually when you start, so there is a synergy. A synergy of ceftazidime avibactam with estrionam. So if you want to give somebody the benefit of this ceftazidime avibactam, then you have to combine it with estrionam, not meropenem. That is what is the usual synergy drug that we have shown in one of our presentation there in TTS webinar that synergy can be done if you do testing with both of these together in cases like this. Okay, sorry, continue.
Yes, sir.
Sorry to interrupt, sir. Actually, what happened in this case, we found that aminoglycoside sensitivity was there, but keeping in mind that creatinine was there, so we didn't start that initially. And we found that being in government setup and patients' economic constraints, we could not start Istunam. And neopenem, ceftazidime, avibactam were available in house, sir. So we started it, sir.
No, I understand, but then again, comments. I did not want to make these, but there are two things. One is that even if the patient, see, this patient has graft dysfunction because of pyelonephritis. So you have to adjust the doses of the antibiotics according to the renal function, even if it is a nephrotoxic antibiotic. You can always give that. Here there is a because this is a graft pyelonephritis, unless you give the medicine which is required. This is a symptomatic urosepsis and pyelonephritis. Secondly, I can't really so. But this is a patient who underwent a robotic kidney transplantation. Robotic kidney transplant is a hell costly affair. Means so saying that he is not affordable. But in the government hospital, I think you get the antibiotics through the hospital management, isn't it? Hospital provide those medicines.
Yes, sir.
Okay, please.
So urology opinion was taken and DG stent was removed on day 5 of admission as it was thought to be one of the sources of infection. The further workup was done and we monitored the CBC and the KFT levels daily. And we found that the creatinine was on the increasing trend. The fever spikes were also continued to persist during the stay of the hospital of the patient. The same has been shown in the chart below as well. Then following that, we had also repeated the blood culture sensitivity after starting the antibiotics, and the cultures were repeated, which were reported on 16th of November for both blood and urine, and they consistently showed E. coli, which was sensitive to colistin and gentamicin and fosfomycin. MR urography date was taken on that day for the patient just to find out if there is any urinary tract abnormality, as that was also one of the considerations that we were taking in. Following that, we had finally switched to injection gentamicin and fosfomycin, and the rest of the things were continued. In view of life-threatening infection, MMF was stopped. The CBC and the KFT levels were monitored. Finally, after starting the antibiotics, there was a steady decline in creatinine, which was noted, and the TLC levels also settled, and the patient, however, stayed anemic. This is the chart where we've shown that the serum creatinine levels were finally in the decreasing trend. Finally, we got a date for MR urography, which was performed, and it showed that the patient had bulky transplanted kidney, showcasing loss of corticomedullary differentiation with tiny cortical cysts, most of them showing diffusion restriction and few hemorrhagic cysts with perinephric fats trending. And heterogeneous collections was noticed adjacent to the upper pole and adjacent to the lower pole along the pelvic wall. Another collection was adjacent to the hilum, which was noted, and an impression of acute graft pyelonephritis with infected cortical cysts in the perinephric collection was made. These are the MR urography films, wherein we are seeing that the patient has cortical cysts, along with there is also adjacent collections which are noted in the second picture, and in the third picture also we've shown that there are cortical cysts and the collections. Adjacent collection to
Could
the
you make
pelvic
this a
wall.
full screen? Make it a full screen, please.
Yes, sir.
Yeah. Okay.
Yes, sir. Therefore, there was a revised ultrasound whole abdomen was done in correlation with the urography, because the MR urography initially was not consistent with the initial USD report that we had got. And here it was showing another this report was consistent with the MR urography report that we got. Heterogeneous hypoechoic collection was seen even in this one, in the to the upper pole of the transplanted kidney and adjacent to the lower pole along the pelvic wall. The patient's condition after starting the antibiotics improved significantly, and the patient also became afebrile. Another repeat urology opinion was taken, and the patient was advised to continue the conservative management with IV antibiotics. Now the patient.
So how did the doing MRI change your treatment plan or treatment decision?
Sir, we were thinking that they would want to go ahead with some tapping or some kind of intervention from their side. However, they wanted us to continue with the IV antibiotics, because initially when we had taken the date, the fever was not subsiding. So we wanted to find out if there is any other source of infection which we are missing out, if any structural abnormality is there, which is why we had undergone for the urography.
Yeah, but I tell you, the plain CT is enough. If you do a plain CT, you will know about the collections.
Okay, sir.
So you don't need to go such a complex sort of investigation to find it out, because
Okay.
any collection or anything which will you can get a CT plane which is easily available, and then if required, then you go for the higher investigation. Yeah.
Okay, sir. Here the plan was to continue the IV antibiotics for 2 weeks and to switch the patient to oral and discharge. This is the TLC report. So what happened after we started the antibiotics, the patient was found to have leukopenia, and on 28th of November, the patient developed leukopenia, in view of which we stopped the valganciclovir and Septran, and we also sent CMV DNA PCR to find out if there is any other cause, and which came out to be negative. Therefore, a hemat review was taken, and fosfomycin was stopped because it was suspected to be fosfomycin associated leukopenia. Leukopenia following that improved, and the patient stayed asymptomatic, and the MMF was restarted prior to the discharge.
Now, see, this is most likely well-encyclovir induced leukopenia. What doses he was receiving well-encyclovir?
Sir, 450 modified renal doses were going on.
Yeah. So chances, see that this is a patient who would need fosfomycin even later on, as a oral. Once the acute episode subsided,
Yes,
he
sir.
received adequate IV antibiotic for 2 weeks or so.
Yes,
There's a
sir.
very high chances of relapse. You have to continue fosfomycin sachet in this patient, otherwise he will come with again a relapse of the UTI, and it will have very hard time treating this type of patient.
Okay, sir. So the final diagnosis was made of urosepsis, graft pyelonephritis with cyst infection and perinephric collection, secondary to MDR E. coli with fosfomycin associated leukopenia. Discussion. There were very few antibiotics which are found to be sensitive to MDR E. coli, and few of them include meropenem vaborubactam or ceftazidime avibactam, or there is another one which is cefiderocol with alone or in combination with ceftazidime avibactam combined with aztreonam. And there is another, or we can just give ceftazidime avibactam. So these were a few things which I found in one of the journals which might be sensitive to MDR E. coli. Post-transplant UTI. So I wanted to propose a classification for post-transplant UTI where we can classify it as immediate, early, or delayed, as there is no such particular classification within the literature, where we can take immediate as UTI occurring between post-op day 0 to 1 month, early 1 to 6 months, and delayed more than 6 months. This classification will help us in early diagnosis and judicious management, and will also help us provide timely treatment to the patients. There are very few journals with fosfomycin associated leukopenia. These were the 3 which I found. So this was the 4th case that we came across with fosfomycin associated leukopenia. The following conclusion was made. MDR UTI is a life-threatening infection in post-transplant patients. Post-transplant MDR UTI needs to be diagnosed early and treated promptly. Immediate post-transplant UTI can be either donor-derived or iatrogenic. It needs to be evaluated in detail, both microbiologically and radiologically. And IV fosfomycin should be used with caution in patients who are transplant cases, as it may lead to leukopenia, which is reversible. Thank you.
Thank you, Dr. Shukriti, for your presentation of MDR E. coli.
Thank
I
you.
think we can have a good discussion over that. Dr. Saurabh, your comments.
Thank you, Dr. Sujati, for a wonderful presentation.
Thank you, sir.
There was, so regarding Shyam sir's comments on leukopenia, then we first stopped Valgan only, sir. And as after stopping Valgan also, the TLC was decreasing. We waited for some days. Then we planned to stop fosfomycin, taking due consideration what you have guided. We had to continue fosfomycin, but because of these restrictions, we had to stop after completing 2 weeks. We completed 2 weeks of antibiotics in this case, sir.
Yeah, it could be because there are case reports, but then there were other drugs also which are more commonly causes leukopenia. So there are some case report of fosfomycin, but see this patient, because we see a lot of patient with post-transplant UTI, and this patient has multi-drug resistant. So I would say this is the in such type of the cases, either you have to give this colistin or aminoglycoside because or phosphomycin, or sometime we have found, because this sensitivity this is not always available, but you can also try the LRS, which is non-nephrotoxic drug. And we have found many of our patients, because we do the sensitivity testing, and it is effective, and some of these patients do not require nephrotoxic antibiotics. So that can be tried, but obviously the treating infection is most important, and you have to keep in mind the dosage and the duration of the treatment to reduce the risk of the nephrotoxicity.
So,
Yes.
currently the patient is on what drug actually?
Recently, patient has been on triple immunosuppression, and
Antibiotics?
antibiotics. We are following her up, and as we completed 2 weeks, later on we plan to shift to fosfomycin again. If the on the oral fosfomycin, but as the plan was to continue on fosfomycin orally, and as she was sensitive to aminoglycosides, the 2 weeks of IV aminoglycoside was completed, and as patient developed leukopenia, so we continued her on oral ferropenem, and patient is on close follow-up, and presently there is no issue.
Okay. I think 2 weeks, I think 3 weeks has to be the norm for this kind of resistant infection.
Yeah,
Shyam, what is your comments? Yeah, Saurabh, go ahead.
Sir, we planned to continue for 3 weeks initially, but as the patient recovered very well, and fosfomycin caused leukopenia, which was the main antibiotic sensitivity, because with the gentamicin there was intermediate sensitivity and full sensitivity with fosfomycin, so we had to stop, sir.
No, the thing is that this patient, see, this is a post-transplant patient, and probably the response started coming in 3-4 days, and then once the patient became better, he was treated for 1 week more after this. Giving more than that, actually, the chances of nephrotoxicity will increase. But this patient would definitely, in my opinion, would need some continuation of the fosfomycin oral, which has also been found to be effective once you taper down. There's a study which have shown that even that in pyelonephritis, you can give a maybe a 7 days or 10 days of the and IV and then switch to oral. But in transplant scenario, obviously you would like to treat fully for at least 2 weeks. So I would, because the risk of the nephrotoxicity, I would, if patient has done well, I will stop at 2 weeks, but continue something so that patient does not relapses.
Yeah, I agree, sir.
Or have you looked for BK virus? This patient, have you looked for BKV?
We planned initially to send the BK virus profile also, but what happened as the cultures were positive and we had a microbiological diagnosis, so we didn't send, sir, because patient had to pay and the patient was poor, so that
Okay.
we had to manage accordingly, sir.
Yeah, see, the BK virus infection usually occurs after first month of the transplant. In this patient, I think the UTI occurred after 2 weeks, and this patient presented with high-grade fever, all the features of UTI and everything. So the suspicion of the BK virus would be low in this patient, especially
Okay.
because you have one cause which is clearly identifiable. You have urine culture, you have blood culture, you have pyuria, and you have leukocytosis and graft tenderness and everything attributable.
Yeah, I agree, sir.
So what is your consensus on DJ stents? Do your center routinely keeps stenting for all live related transplant, or any special scenarios they are having at stent?
No, like we in our hospital, because it is a multidisciplinary approach, and we have to continue the placement as per the urology choice. So the
Okay.
urologist here, they are more comfortable to put digestant, and but we have experience of not putting digestant in some scenarios in which as per the convenience of urologist. Like when I was studying in Army Hospital R&R, we in some cases urologists were in opinion not to put digestant. They did some study also, and they found that not putting digestant was associated with more complications, clinically significant complications. So we continued to put digestant there also.
Dr. Sham, in your center, you'd use regular DJ stents, and what time
We
frame
use
you will
regular
remove that?
DJ stent and we remove after 2 to 3 weeks. It has been actually studies and found that except for very some of the surgeons might not put usually, but then most of the transplant surgeons they put DJ stent and the complications are higher if you remove DJ stent before 2 weeks. So the usually after the 2 to 3 weeks, so you should not keep it more than 3 to 4 weeks. Then again the chances of infection and other complication increases. So our center we routinely put DJ stent and remove them at 3 weeks, sometime early if there is any suspicion of stent related infection, and it significantly reduces chances of the complications.
What about Foley's catheterization? How post-operative? How many days you will be removing that? After how many days?
We remove on day 5 in most of the patient except those who have some urological issues and we want to wait for a bit longer, but the it's day 5 we remove the Foley's catheter in all our patients.
Do you routinely screen for donor urinary tract infection prior to transplant, the urine culture of a donor?
Yeah. So this is important. You need to do the urine routine culture of the donor, and if there is any infection, you have to treat it in the
Routinely, you will be doing for all, no?
Yes,
For
yes.
all
For
prior to
all.
transplant, 1 week prior to
Right.
transplant.
Yes.
That's fine. So CRE strain, aztreonam has to be combined with the ceftazidime avibactam.
Yes.
Carba R assay, do you have any idea of about Carba R assay? I'm never about.
No.
We
So
are
there.
talking carbapenem resistant.
Carbapenem resistant assay. Okay.
No, so there are some new drugs like this combination of the meropenem plus the beta-lactam newer antibiotic, which are useful, but they are not available in India. In India, you have this ceftazidime, avibactam, and this combination, which can be used in synergy. And you have to but do a synergy test to find whether this
Okay.
is actually effective when you use them together.
Yeah. We often combine Aztreonam ceftazidime with the ceftazidime avibactam with Aztreonam. No?
Yes.
If is there no other questions I have answered all? So from the points taken here is to go for a cultures and resistant strain, and you have to look for the synergy of CRE, if you happen to have a CRE strain. And consensus here is degestant has to be removed in 2 to 4 weeks after transplant. And antibiotics is a key for a graft pyelonephritis, keeping aside that renal toxicity. And the resistant organism, at least it should need a minimum of 3 weeks of antibiotic therapy. And with no other further question, and I must thank both the panelists, Dr. Shyam and Dr. Saurabh, and who, in spite of their busy work, who came in and chipped in with good responses, good inputs, and we learned good from them. Actually, from the new, certainly two peculiar case of Lepromatous leprosy presenting immediate post-transplant, and we should have in mind whenever you have that lesion with paresthesia, because nobody is thinking of Lepromatous leprosy because it's very rare in this day. And thank you to brought in notice this kind of issues. And again, dealing with the multi-drug resistant UTI is, of course, a challenging one because it's one of the most important complications of post-renal transplant. And we had a good discussion over UTI. And I must thank both the presenters who did the very good slides, and they are presented clean and crisp. And thank you very much for the wonderful presentation, and both VR and Prime. And I must thank the delegates who have attended this meeting. And I must thank the MQ team for providing the technical platform. And this is our last meeting of this year, 2024. We'll be back in January 2025 next year with 2 important peculiar cases. And we invite the institutes to come up with the good cases so that we can have a good learning of 1 hour monthly for every Saturday, so that we can brush up our knowledge of transplant. Thank you very much, one and all, for your wonderful participation, and wish you all an advanced happy New Year. Thank you.
Thank you, Raja.
Thank you, sir. Thank you, Shyam, sir.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you.